Good afternoon, everyone. I can tell the mic is working because it's lovely and loud. Before I make any remarks at all, we're going to start with an Island Health welcome video, and then I'll actually do the welcome that I would normally do. So I'm just going to...
Serving 875,000 people, Island Health's focus is the health and wellness of the residents and communities on Vancouver Island and in surrounding coastal communities. Our diverse geography spans 48 settler communities and 50 First Nations, from the Zawadenu people of Kincombe Inlet to Victoria, from Tofino to Comox. We acknowledge with respect and gratitude our privilege to provide health and care services on the traditional unceded territories of the Coast Salish, Kwakwaka'wakw, and Nuu-chah-nulth cultural families. The Island Health family includes 27,000 healthcare professionals and 1,000 dedicated volunteers. 2,900 doctors, nurse practitioners, midwives, and dentists make up our medical staff. We provide health and care services at 145 facilities, with more than 6,600 long-term care beds, nearly 1,400 mental health and substance use beds, and more than 1,800 acute care and rehabilitation beds. Island Health has an annual budget of $3 billion. Each year, this funding supports 491,000 visits to emergency departments, more than 73,000 surgeries, 59,000 MRIs, 152,000 CT scans, 2,100 telehealth visits, more than 51,000 visits to urgent and primary care centers, over 16,000 home health monitoring visits, and 463,000 home health care visits each year. Island Health has expanded our primary care services with 7 Island Health urgent and primary care centers, and we partner in 3 community health centers and 7 primary care networks across the region, with further expansion in the works. Under the leadership of 6 medical health officers, Island Health works to promote health, prevent disease, and improve quality of life. Each year, we conduct more than 2,000 inspections of childcare facilities, 600 inspections of licensed care facilities, and 4,500 inspections of food service operations. Public health nurses provide more than 5,000 perinatal home care visits, and in partnership with First Nations Health Authority and community pharmacies, more than 2 million COVID vaccines have been provided in Island Health. From before birth to end of life, Island Health strives to provide excellent health and care for everyone, everywhere, every time.
Well, again, good afternoon. I'm Leah Hollins, the Chair of the Board of Directors for Island Health. On behalf of my colleagues, welcome to our public forum, whether you're joining us here in person in the Oliver Woods Community Center in Nanaimo or online through our live stream. I acknowledge with respect and gratitude the traditional unceded territories of the Nanaimo and Snow-Nawas First Nations. And I'm so grateful now to introduce Lolly Good, an elder from the Nanaimo First Nation, to start our meeting in a good way. Thank you for coming.
Hi, Scott. Can you hear me? Awesome. Ai square, ai kwanesi lamnala. Good day. It is good to see you all. Siemna sietya, antha, schreitsolwet, Lollygood tennis, Juanita Math na squish, Tunisa at Nanaimo, Equamlo at Seashell. I was born and raised Nanaimo, extended family roots, Seashell. I'd like to acknowledge worldwide all frontline workers who risk their lives on a daily basis in support of their cities, towns, and countries. Nanaimo shi CME Mastaya, Tlash, Shut Thumbs, Mak, Uchacha Tamach. Nanaimo Chief Mike Wise and Council invite you all to our sacred land / traditional territories. While I recite this blessing, I'd like you to think of others. Sisat Siem, Haichka Atanaquel, Thi Huam, Lalamathot, Atakikalis, Ikaki, Mastaya, Haichka, Atasaltan Satanaquel, Thi Huam, we at Slachen, Atalatems, Sisat Siem Thi Huam, at Wataucha Satanaquel, Itamak Square, Stilatlamste. Creator, thank you for this day. Please look after those who are grieving and for those who are sick. Thank you for the food today. Please bring blessing and medicines to our tables. Creator, please help us all today and every day. Ni hai. I'm going to sing a song, and the song is about asking for help.
Welcoming us today. My gratitude to you for being here for us and for inviting us onto your territory.
Do enjoy your gathering your meeting, but be safe. COVID is still out there, so just be cautious.
Thank you. Thank you, Lolly. We're very grateful that you were here with us this afternoon. Public forums like this allow the board to meet people and communities we serve and are essential to our commitment to transparency and accessibility. Our time together will help us better see what matters to most of you, and most of you have an issue that matters, so we can increase our understanding and refine our thinking. As a governance board, we are responsible for the overall direction of Island Health. The Minister of Health appoints the board, but we each choose to sit on the board because we care deeply about health and care. As a former nurse, a Deputy Minister of Health, and Chair of the Canadian Blood Services, the patient has always been central to my work. I always ask myself, is what I am doing right for the patient? Because caring for patients is why I started working in healthcare and continue to support the delivery of health and care. We have a full program today. Dr. Sandra Allison, Medical Health Officer, will speak about public health and wellness in the region. We will then have presentations from CAR 5-4 and Island Crisis Care on how, in partnership with Island Health, those in our community with mental health and substance use challenges are supported. The last part of the agenda will be an opportunity for you community members who have come to our meeting and submitted questions by email in advance. I will open the floor to questions so the board can hear from you. And I'd just like to remind you that we need to keep it short to allow as many people as possible to ask questions. First, though, I want to invite Island Health's President and CEO, Kathy MacNeil, who will begin by providing an update on the delivery of health and care services across Vancouver Island, and particularly here in Nanaimo. Kathy.
Thank you, Leah, and I just wanted to thank Elder Lolly, who's just left the room. She always opens up our work together in such a good way. I too want to acknowledge that I am very grateful to be here on the unceded territories of the Nanaimo people and the Sunawas First Nation here in the north part of Nanaimo. I also want to recognize the Inuit, the away from home Indigenous people, and the Métis chartered community here in this region. I'm also grateful to the community of Nanaimo, and nice to see community leaders here with us today. And also online, virtually. Thank you for joining us here at this forum and caring so deeply about the community that you live in. It's a challenging time for communities everywhere, including here in Nanaimo, when it comes to issues related to people who are unhoused and struggling with mental health and substance use. And we know that the solutions to this particular challenge are multiple, complex, not simple, and they require many partners to come together across agencies with the participation of the community. We work closely with community partners to do what we do at Island Health to deliver health and care, and many of our partners are here in the room today, started our day with us, and so very grateful to them. There are no easy answers, and it takes all of us working together in partnership to raise the community up as a whole. As Leah said this afternoon, we're going to hear a little bit about some of these partnerships, two of these partnerships in particular. CAR 5-4 is a joint initiative between Island Health and the Nanaimo RCMP, where together they attend urgent calls to support those in crisis. Also, we'll hear from the Island Crisis Society, which through housing and Island Health partnership programs, helps people stabilize and find the support, resources, and services they need to meet their healthcare goals. We've partnered with BC Housing and local housing operators to deliver complex care housing, which was announced last year by the provincial government. Teams are preparing to welcome clients to their new home. In terms of health supports, we recently added a second assertive community treatment, or ACT team. We're very famous for our acronyms in healthcare. The ACT team focuses on individual clients and their recovery. The program helps people with the most serious mental illnesses connect with community living, psychosocial rehabilitation, and recovery supports. From housing to care, there is much more work that all partners, including Island Health, need to do to support people living with mental health and substance use. And we are committed to that work, walking alongside our partners. As we discuss the challenges that communities face, it's important that we don't lose sight that these are people, they're individuals, they're brothers, sisters, daughters, sons, who are in need of support. The toxic drug outbreak or crisis has claimed 330 lives in Nanaimo alone since that public health emergency was declared in 2016. I'm sure many of us in this room and watching online have lost someone or know of someone who's been lost because of that toxic drug supply. These people are people who matter to us. They're our friends, our family, loved ones, and members of this community. Like Elder Lawley, I want to thank community partners and frontline workers who are dedicating their lives every day to try and stop this. Without you, these numbers would be far higher, and your work is critical to keeping people safe. One of the other things we had an opportunity to discuss with partners this morning was how to best support our local hospital here, Nanaimo Regional General Hospital. We know hospitals are a key piece. They are critical to the healthcare system. Like other parts of the healthcare system, as we come through this pandemic, they are under considerable strain. Here in Nanaimo, our emergency department is the busiest on Vancouver Island, seeing an average of 195 patients each day. Delivering care with this number of people coming through the doors can be challenging. However, even in these circumstances, the emergency department staff and physicians perform the most efficiently of any large emergency department we have on Vancouver Island. The time from triage to seeing a physician is on average 90 minutes. So even with that large volume of daily emergency department visits, it takes less time to see a physician here than at some of our other hospital sites. And this is 100% due to the commitment of the staff and medical staff to constantly improve quality. We know waiting for surgery can be incredibly challenging. It impacts your personal life and can impact your ability to work. That's why we continue to invest in expanding surgical services in Nanaimo, and we've seen several improvements in the last few years. Hip and knee replacements normally require an overnight stay at the hospital. Now here in Nanaimo, some patients who are medically appropriate can have the procedure done and be back in their own home that same night. We've increased the capacity for many day procedures, including a 330% increase in the capacity at the Center Island Surgical Center. In March of 2020, there were 2,700 patients on the wait list for cataract surgery here. Today, there are less than 1,200 patients on that wait list. This helps people get back to their lives sooner. Teams at the hospital are doing great work, and they're doing so in very challenging infrastructure. Parts of the hospital are dated, and we know they need updating. Just 2 weeks ago, we announced investment in the new 12-bed permanent high acuity unit to replace the one that was put in place as part of our COVID response. When this unit is completed, it will support patients needing a higher level of care than a regular medical bed, but who don't require the full support of an intensive care unit. And the intensive care unit is under construction, we're anticipating opening later this year. Just like the emergency department, Nanaimo Regional General Hospital's critical care teams do incredible work. The province has made significant investment in cancer care. A concept plan for a new cancer treatment facility to be located at Nanaimo Hospital has been approved by government, and a business plan is our strong and robust community-based care services, including primary care. Working in partnership with local physicians and other partners, significant investments are being made here in Nanaimo in primary care. The Nexus Nurse Practitioner Clinic has been operating in the community for just under 2 years. 3 new-to-practice physicians have signed contracts to work at family physician offices in Nanaimo over the past year, and 3 more are in contract discussions. 2 nurse practitioners are now working out of the Snanawas Health Center and Tillicum-Lalem Health Center. The Medical Arts Urgent and Primary Care Center averages 2,000 patient visits per month. We know there is much more work to do to increase primary care access here in Nanaimo, and we will continue to invest in additional services for the community over the coming months and years. Investing in community care resources is another one of our organizational priorities. By supporting people in their homes, we can reduce demand on hospitals and provide better care. Even with health human resource challenges, home support hours increased here in Nanaimo by almost 10% last year. And how home support is delivered is also changing, moving beyond the traditional service model of daytime and early evening hours. 2 mobile overnight home support teams have been launched to provide service to clients who might have unscheduled care needs so that they can remain at home. And we know nighttime can be difficult for a family and for people who might be living at home. Community teams are now working in the hospital. A rapid response team consisting of registered nurses and home support community health workers support discharges from the emergency department and inpatient units and provide same-day service to ensure successful discharges home. I want to thank our many partners who continue to help us grow services at Nanaimo Regional General Hospital. And there are 3 groups in particular I'd like to note here in the public forum. The Nanaimo Medical Staff Engagement Society represents all of the physicians working in the hospital. I want to thank them for their continued efforts to ensure patients at the hospital receive the best possible care. I'd also like to thank the Nanaimo Hospital Auxiliary and their team of volunteers for their incredible efforts over the many years to support NRGH. Over the last 10 years, the Auxiliary has raised over $4 million for the hospital. I'd like to thank the outgoing Auxiliary President, Phil Roebling, for his tremendous contribution. And I know I met this morning Deborah Francis, the incoming president, and her team will continue to do great work, and we're very grateful to them. I'd also like to recognize the Nanaimo and District Hospital Foundation and officially welcome Barney Ellis Perry, who joined as the foundation's new CEO last year. Barney's at the back of the room, for any of you who'd like to meet him. The foundation is a powerhouse in the community, raising over $5 million for the hospital's new ICU and committing an additional $5 million to the high acuity unit. Island Health is fortunate to have such a strong partner. Thank you, Barney. And Janice. Janice, the legacy of Janice. It's vital Indigenous patients and their families always feel welcomed, heard, and supported, and that our services are provided in a culturally safe and respectful way. Through the Cultural Safety Collaborative, NRGH and Sunamic First Nation continue to work together to address care-related concerns. There are now 3 Indigenous liaison nurses working on site at NRGH with 7-day-a-week coverage. One of the Indigenous liaison nurses is dedicated to providing support solely in the emergency department. I'd like to thank and recognize the partnerships with Nanaimo and Tillicum-Lalem Friendship Center who host these positions. As you saw in our video, at Island Health, our vision is to provide excellent health and care for everyone, everywhere, every time. We work to create healthier, stronger communities and a better quality of life for those we touch. This work is rooted in our care values. They guide us in good times and in times of uncertainty. They help guide us through the pandemic, and they continue to help navigate through these challenging times. We know that our care values are evident in the work of our staff. On that note, I'd like to share a piece of news. Island Health was recently surveyed by Accreditation Canada, an independent organization which assesses healthcare organizations in Canada and around the world against evidence-based standards. At the end of the survey, we received accreditation with commendation status for going beyond nationally recognized standards of excellence for delivering services focused on improving quality, safety, and experience of care for patients, families, and staff. I'm proud to say one of the teams contributing to this success that was identified was Nanaimo Regional General Hospital's medical daycare team. And I want to thank this team and the rest of our dedicated workforce who consistently provide excellent care to residents across Vancouver Island and the region surrounding. Earlier, I spoke about our vision and values. We returned to them repeatedly during COVID, especially when we were uncertain and didn't have a clear roadmap, and I can remember those early months of 2020 when that was absolutely true. Returning to the basics, our vision of excellent health and care got us through. The only road ahead to achieving results is the one we walk together, across silos and departments, across organizations, because we are all in service to the people who need us. We're committed to this vision and will continue to provide safe and reliable care. Our incredible teams are dedicated to caring for this community and rising to the challenges before them. It takes local collaboration and partnership to address these challenging issues because it's at the local level we can make the greatest difference to the people who live here. I want to thank all of you for being here today. Thank you for letting us share the work that we're doing in health and care. And now I'd like to hand the podium to our local medical health officer, Dr. Sandra Allison, who will share some data and information about our local population health in this region.
Thank you, Kathy. Can everybody hear me? I even get the clicker today. I don't even get the clicker at home, so that's pretty great. Thank you very much for inviting me to speak, Chair and Kathy. I really appreciate the leadership of the executive leadership team and the openness of the board to be in community. I know that that's really important, and so I just want to thank you for that. I'm grateful to live, work, and play on the ancestral lands of the Coast Salish, Nuu-chah-nulth, and Kwakwaka'wakw people, and specifically the Nanaimo people. I'm very grateful to them. And every day in my work, I really strive to improve environment, community, and health for Nanaimo people here. So that's my commitment. I acknowledge the work of the Population Health Assessment team because also I couldn't do my job without them. They give me data, slides, fancy things to show you. And any data that I refer to here is gathered from multiple sources, and so I'm happy to talk about that after if you like. Oops, too fast. I have to go. Okay. So thank you, everybody. The population of Greater Nanaimo local health area was about 123,000 people in 2021 with a median age of 51.6 years. That's old people. Population growth in the gray bars on the graph is anticipated to steadily increase. You can just see the increase in the population growth gray bars. Over the next 20 years to about 164,000, that's a 33% increase from today's population. Like, that's huge growth. And we know that, it's on the front page of the paper, right? CBC got paper, articles, fastest growing communities in Canada. We're one of them. So proud of that. And I have to tell you, I'm incredibly proud to live and work here. And working for Island Health for sure. So that over 75 population segment, that's that blue line that you see climbing. And I'm looking at you, Lorraine. We really have to pay attention to the aging population and how we serve people to age healthily in place. So thanks for that. And I know I was committed to 10 minutes, I think, so I better go faster. When compared to the Island Health average, Greater Nanaimo has a lower percentage of private household members, and this is according to the 2021 census, reporting Indigenous identity. Oh, geez. Sorry, you guys. I'll learn it. While the median age in Nanaimo is near 52 years, when we look at low income rates in this area, the blue bars are Island Health, like the light blue, and the dark blue bars are BC. And Greater Nanaimo area is the green. And you can see 1 in 8 children and youth and 1 in 10 adults are reported to have low income after tax in Nanaimo, and that's pretty significant. Less or fewer who's the grammarist in the room? Fewer seniors have report low income in the area, and that's important because who votes? We have older people that vote. We have poor families and children, just naming it. Name it, claim it, right? Right, all right. And in 2021, just so you're aware, 8% of Nanaimo respondents reported unemployment, and that's just below the provincial average, so we have less unemployment here, 8.4% provincially. In the housing, this is really important stuff in Nanaimo. You guys know this. For renters in Nanaimo, what I'm showing you here is the percent of people who report spending 30% or more of their income on their rent. And that's a core housing need. That's one of the attributes of it. And 41% of people, Nanaimo's the top bar, report core housing need in Nanaimo for renters. That's really important. And also, I did a little research on my own on the internet, publicly available information about shelter beds in our community. We have about 100 shelter beds. It's Nanaimo here. The 1 shelter bed per population, 1,000 population. When you compare it to cities like Victoria, where there's been lots of investment, 4 shelter beds per 1,000 population. Our neighbors in Oceanside, 0 beds per 1,000 population. Duncan, half a bed. I think there's even a pointer on here if I tried. Duncan, half a bed. Nanaimo, 1 bed. Ladysmith, 1.1. But here, Victoria, 4 beds. So I think, and maybe it's just me, I don't know, if we had more shelter beds, maybe we would have less people without a bed. I don't know. Okay. Post-secondary education in Nanaimo. About 63% of Nanaimo residents aged 25 to 64 report post-secondary certification, diploma, or degree. So that's just slightly below the provincial average of 66%. It's well recognized that educational achievement is associated with improved health outcomes through income pathways. At near 15%, Nanaimo has a proportion of single-parent homes that is average for the Island Health region and the province. Life expectancy for residents of Nanaimo area is on par with BC, and Health Authority averages with 81 years is the expected age at birth. When broken down by sex, though, females in Greater Nanaimo have a shorter life expectancy than BC females, and this has decreased sharply since 2018, attributed somewhat to the overdose crisis, attributed somewhat to the COVID. Did I just say the COVID? I did. Okay, whoops. Children's health indicators do show, what happened? Okay. Sorry guys, I don't know. This is magic. Sorry about that. Children's health indicators, including parent-reported child stress, the early developmental instrument results show that children in the Nanaimo Ladysmith area have greater vulnerabilities on school entry. Nanaimo respondents, and that's adults, greater than 18, COVID Speak surveys were done in 2020 and 2021. And just so you know, there's another one being repeated in 2023, so everybody fill out that survey at the time. But Nanaimo respondents showed worsening self-reported mental health, diminishing protective factors, including reduced sense of community belonging, less connection with friends and family, and increasing senses of helplessness. There's increasing incidence rates of mood and anxiety disorders, and that's been persistently increasing since 2017, and that's before the pandemic. Pandemic just made it worse. In Nanaimo, and the region and the province and Canada and Western Canada, unregulated drug toxicity deaths continue to be on the top list of causes of death. top 2 causes of death in ages up to age 59. So the yellow bars on this graph, it's really killing people. And the potential years of life lost for those dying in the emergency is overwhelming. Potential years of life lost mean we expect people to live to age 75, and anybody that dies earlier than that has lost some potential years to spend with their children, with their parents. All right. In Nanaimo specifically, the number of deaths continue to increase every year, with 80 deaths in 2022. And you heard Kathy, thank you for getting that number, 330 deaths in Nanaimo since the beginning of this crisis. That is an amazing number of people in our community. It's touched everybody, it certainly has. When you look at that rate at the end of 2022, that's the graph on the bottom, we were about 50% higher than the Island Health rate. Here's the greater Nanaimo rate, about 50% higher, but counting the small number of cases that we had or deaths that we had in 2023 in the first month, it's an amazing increase. And why? Is it January? Is it hopelessness? Is it a whole bunch of things happening? Just a number of deaths? I think we'll see that rate stabilize, because it's small numbers, but it is shocking when you see that. But what I'm worried about is this continued rise to 50% higher than our regional rate. And those deaths are concentrated in downtown Nanaimo and South Nanaimo, so just really wanting to flag that those areas are hit really hard. So we know that when we're planning for services, we got to think about where we're going to do that. I also want to reflect on the disproportionate impact to Indigenous people in our communities in both paramedic-attended events and in the fatalities. First Nations Health Authority reports that Indigenous people are 5 times more likely to experience than other BC residents a fatal drug poisoning event, and Indigenous women are 9 times more likely. Indigenous women are 9 times more likely to experience a fatal drug poisoning. That's shocking. Opioid samples that have been tested in the Vancouver Island Drug Checking Project, really give us a sense of what's going on in our neighborhood and our communities. And about 20%, or only 1 in 5 samples submitted for opioids, because somebody suspects it's opioid, is actually what they think it is. 4 out of 5 samples are contaminated with fentanyl analogs, xylazine, or other adulterants, bromazolam being the most common benzo contaminant. I'm very grateful to mental health and substance use teams and the work that they're doing to expand programs and access, both in inpatient and community settings. And we're hearing about innovative ways to really meet the needs. And I thank my partners as we do this together. Public health services are really working hard on prevention, working closely with community partners, like at the school wellness clinic, trying to help get in front of some of the burden in youth. But we certainly need to do more to improve youth resiliency and mental health in youth. The Right from the Start program is a way that people can be connected to care. Newly pregnant people can be referred to care so that we have good prenatal care right from the start. But I really want to just reflect that our health system is grappling to reduce disease, injury, and mortality, doing everything we can, but many of these are downstream consequences of risk behaviors and social factors. We know that these health consequences are a direct outcome of social, institutional inequities that contribute to challenges in living conditions and access to determinants of health. In conclusion, many of the determinants of health in the area in Nanaimo are lagging, specifically proportionally more children living in low-income households in core housing need based on rental costs, more children that don't have the skills they need to be successful on school entry, and these contribute to negative life situations across the life trajectory and the health outcomes that we're seeing. The toxic drug poisonings in Nanaimo continue to escalate with disproportionate impacts to First Nations people, including First Nations women, and the drug supply in community is highly contaminated with harmful adulterants like fluorofentanyl and xylazine. Deaths are occurring more frequently in the downtown and South Nanaimo area in private and other residences. Our health authority team continues to collaborate with necessary partners, including primary care, community, and ministry partners to create the wellness supports needed in community. But there's a lot of work to be done, and I really appreciate you saying, Kathy, that everyone has a role in improving wellness in Nanaimo. This is not something we can do alone, and it brings me to tears if I think about how hard this has been for community. So thank you.
Thank you, Dr. Allison. One of the most important aspects of us having a gathering like this is to hear from our medical health officers. And I agree with you. It does make us want to weep because we can't seem to figure out how to fix our problems in the community, and we have to do that together. None of us are going to be able to do that independently. So I was hoping that our colleague Diane Brennan was going to join us. She's from Nanaimo, but she hasn't arrived yet, so I'm going to take the opportunity to introduce my other board colleagues to you before I introduce the next speaker. And the board consists of normally 10 directors, but we have 2 vacancies right at the moment. And so, as I mentioned, Diane is from Nanaimo. Shawnee Cassavant is from the Hupatchesett and Sechot First Nations on the West Coast. And I've heard also Shawnee say was raised in the New Chelmsford territory. Yes. Anne McFarlane from Victoria. Ron Rice, who's a member of Cowichan Tribes but lives in Victoria. Unfortunately, 3 of our board members couldn't be here today. Ron Matson from View Royal, Ann Davis from the Comox Valley, and Alana Nast from Victoria. But I'm ever so glad that my colleagues are here to hear what the public has on their minds. So now we're going to have a presentation from CAR 54, or on CAR 54, which is a joint initiative between Island Health and the Nanaimo RCMP. Our presenters are Constable Josh Waltman, a mental health liaison RCMP officer, and Amanda Lemon, Island Health's manager for community mental health and substance use. Thank you for doing the work that you do. Welcome to the podium.
There's 2 of us. Can we maybe use one of those mics? Are they connected to the same system, or are we sharing the same one?
Sure, yeah. We'll share the space. We'll hold the clicker.
Test, test. Before we start, I just want to give a sincere and humble thank you for having us today and allowing us to present to you guys on our joint initiative. Before we get into it, I just wanted to show you one of the pictures. This is the image that we're presenting and that you'll see in the community. This is my exact, well, this is the detachment and Island Health car that we use. It's an unmarked vehicle to provide a little bit of dignity and to have a little bit lower of profile when someone's in crisis. And then a little bit laid back uniform. And then our nurse also has a vest and a radio as well. My name is Josh. I'm the full-time RCMP Mental Health Liaison Officer and currently the RCMP half of the Island Health RCMP relationship.
Thanks. I'll use this one.
Oh,
if that works. Yeah?
It's the 2 mics. Got it.
Thanks, Josh. And I'm Amanda Lemon. Very grateful to be here. Thank you for having us. And I am a nurse, clearly, and I'm also a manager for the intensive outreach services for Nanaimo mental health and substance use. So this is a new program that we've been working on for a couple of years, and we're able to officially launch in the fall. So we're really happy to share it with you and hopeful for programs like this to grow. So I'll click.
So what is a crisis car? The CAR 54 program is a partnership between the Nanaimo RCMP and Island Health. It was created to provide a thoughtful and coordinated response to people experiencing a mental health crisis in the city of Nanaimo. It's comprised of a mental health liaison officer with the RCMP and an RCMP liaison nurse, like Amanda.
I can give a bit of background of how we got here. Historically, the mental health and substance use teams in Nanaimo have had a strong relationship with our local RCMP detachment, as well as Gabriola Island detachment. And through various iterations, there's a downtown bike unit that our outreach teams work very, very closely with. We sit at multiple tables to try and support folks who are kind of integrating back into community or have some high risk attached to their presentation in community. And we have a community outreach response team, so that's our crisis response team. And they have, over the last couple of decades, consistently attended calls with RCMP General Duty when they've requested the team to come out and do some mental health assessment for them, or the team, when they're in a situation, may call on the RCMP General Duty to come and attend and determine next steps to take if we need to support somebody to get to hospital and things like that. So Josh is the first permanent mental health liaison officer that the detachment has been able to have in Nanaimo. We've had a couple different people in various types of temporary positions over the years, so we've just really been working towards, I think, the moments that we've had in the fall and being able to launch this car formally. So with that, all of those other pieces were built on relationship and trust and working together out there in the field clinically. And now we're happy to say we have a formal memorandum of understanding so that we are able to do this work together. So a little more formalized, so we're stuck together a bit.
Yeah, so just to be a little more clear on that, I guess, is there's obviously a higher level memorandum of understanding between the government and the RCMP that if in an extreme crisis, we can call the hospital and request specific information to support an individual. But what does that look like with the smaller ones? Like sometimes I get notifies and we have to follow up. Are we covered under that? Which is why the specific MOU was created for the crisis car and for Island Health. So now we can share information to provide a coordinated response and to talk about some of the risk of working together, I guess. Not risk, but like how that relationship works and what it looks like.
And our nurse who works in the car, our nurses who work in the car, go through full security clearance screening with RCMP. It's quite a process if anyone's ever tried it. So, but that allows that coordinated response and for them to be able to be together at all times.
So I don't think I'm going to go into reading every one of these, but my point with this slide is that we're not a 24-hour crisis car right now. So what happens when we're off? Well, someone calls 911 or someone calls the crisis line and we get, that call gets diverted to us. The Nanaimo RCMP is extremely capable of responding to calls when I'm off. They have all these skill sets before they walk out the door. We have an incredibly compassionate set of police officers in the city of Nanaimo who are just as capable and have the exact same skill set that I have. The only difference is they don't have the nurse like I have. So I just wanted to make that, I think it was important to put this in here. So under the Mental Health Act, the police technically play 4 roles. We're written into the Mental Health Act for 4 things. The first thing is the police have the authority to apprehend a person with an apparent mental disorder and transport them to a physician for examination under Section 28 of the Mental Health Act. Basically, if we show up on scene to do an assessment, our #1 goal as a team, an Island Health RCMP team, is to keep people in the community, come up with community plans and community resources. If we get to a point where they're not willing to safety plan or they're not reality based or we're in some sort of psychosis, then we have to apprehend them under the Mental Health Act, and then we have to force them to see a psychiatrist. An apprehension is not an arrest. It's not a criminal record. It's just a way for us to get someone to the hospital to get some medical help.
Yeah, and under the Mental Health Act, there's different designated facilities, and NRGH would be the designated facility in this community that an individual will be transported to, and a physician then takes over the care.
#2, assisting in apprehending, assisting the apprehension and transportation of a person under medical certificate issued by a physician, which is commonly known as a Form 4 warrant. So if someone walks into their doctor or goes into Brooks Landing's outpatient psychiatry and says, I'm having obtrusive thoughts on wanting to go and harm somebody, and there's a ways to the means, the doctor can essentially, quote unquote, pink that person, which is a Form 4 warrant, and then they call us and we will get that person to the hospital to see health care. So that's number 2. Number 3 is apprehending and transporting a person on a warrant for examination issued by a judge, which is a Form 10 Mental Health Act warrant. This is a growing one that we're seeing in the community. When I first started, I had 1 in the first year I started. Last year we had 9. And I think this is because I'm promoting it more, as is a lot of other people. So I show up, our coordinated response shows up, and we do an assessment on somebody, and they don't require going to the hospital, but the family member thinks they do. I'm not just going to do an apprehension and take that person to the hospital because the family member says so. We have specific requirements. The client has to be a danger to themselves or others, and not or, but and there has to be a apparent mental health condition as well. So if they don't meet both of those, we can't do it, which sometimes make family members frustrated and upset. So I understand that too. So what we tell them is, you have, as their family member and loved ones, a way better baseline and a way more family history and way more knowledge of this client. You can go onto the internet, print off a Form 9, take it to the courthouse, and give a judge that information, and he can stamp a warrant if he sees fit. Then you come back to me, it takes the thinking out of it, and we'll go and we'll get that person to the hospital. Apprehending and returning patients to a designated facility, a Form 21, this is commonly referred to as being recalled. So if someone goes to the hospital, they can be admitted to the hospital, but they can be found capable to operate or live in the community, but on extended leave. Usually, if they're gonna go into the community, they have conditions like take your medication, see your physician, cooperate or work with your case management team, but heaven forbid you should one day not take your medication or something comes up, then you get recalled by the hospital or the case management team, and the police will come and facilitate getting you back for the treatment that you need.
Yeah, and I think what the whole point of this service and the teams that support folks in the community is that this is the last stage safety piece that needs to occur for somebody, and we do everything that we can in a coordinated response to support someone to remain in their home, stay with their family, work with what other health services are available to them, so that we don't have to enact the Mental Health Act. So I can talk a bit about the process of the actual car. So it's a broadly publicized service now in the community, but the primary access points are through the RCMP, so general dispatch, through other general duty members that might assign a file to Josh and the nurse that are working, and through other various calls that come through the RCMP throughout the day, and then as well through our community mental health and substance use community outreach response team. So they take crisis calls from the community in partnership with the Vancouver Island Crisis Line, and respond to crises. So our community crisis team will also filter calls. They triage and filter calls through to the CAR 5-4 program if they are the most appropriate responder at that point in time. So it really is indicated that an RCMP presence is likely required and a clinician presence is likely required because someone is experiencing a mental health crisis. Our other community mental health and substance use teams also have a good direct link to CAR 5-4 in different situations and may lean on the program for support. So calls throughout the day, and Josh can speak to this a little bit more, but they're triaged based on urgency and acuity. The benefit of having a nurse there who can access health records, can look up someone's mental health history and determine what might be happening for that individual and what has worked to support them in the past. As well, then Josh can also look up through the RCMP system any risks, any things we need to be aware of when entering a scene. The team attends the scene. The nurses, Josh is role is to really secure the scene with the other general duty members that might be present, and then the nurse's role is to engage in mental health assessment. So very often the team is responding to calls that are initiated by family for family members they're concerned about who are experiencing really intrusive suicidal thoughts. And so they will conduct a thorough suicide risk assessment, create a safety plan. And this is really important to highlight, if general duty RCMP are going out without a mental health clinician with them, they don't have anyone to support that assessment and maybe create a safety plan, engage with the family, and often they will have to be transported to the designated facility under the Mental Health Act because that RCMP team doesn't have other options at that point in time. So this is what we're trying to enhance, is the ability to support people where they are in their home, create a safety plan with them or wherever they may be, and keep them there. So the nurse is also then responsible for connecting, for follow-up supports, ensuring that there's a good transition of care plan, disposition for that individual.
Yeah, I think it's important for everybody to know that in the vehicle with me, I have my computer with my information, and the nurse that I work with has their computer with their information, and that's the coordination. Usually, by the time we get to the file, we have a pretty good picture and a pretty good idea of what's going to happen, but we still want to talk to the person because sometimes you never know what's going to happen. But by looking at this information, we can ask strategic questions. We can not traumatize people by bringing up past stories because we know the story. We read it on their healthcare chart. We don't need to ask them to bring that up again because we already know it. So there's a number of reasons why this relationship works so well.
Yeah, and I think we can kind of end with why we believe in a coordinated response to support people who are in high-risk situations and require mental health support. So some of the benefits that we see is really, there has historically been a significant gap between policing and healthcare, and we're trying to bridge that gap and offer people something different. And to reduce harm, acknowledging that with these large systems that we're a part of, many, many people have experienced harm in accessing care within these systems. So anything that we can do to provide a bit more of a trauma-informed lens, really be there for that individual and their family is really, really important.
And again, that can speak to baseline, something that looks, we all come to this, we all bring different lenses and different scopes to these situations. So something that I might think requires hospitalization, I talk to my partner and that's baseline for them. That's they're having a good day. I think that, that just speaks to that.
Yeah, and I think some other, firmly believe that every positive encounter we have with an individual or their family will bring them back into care or create opportunity to engage again at a different time. So that's the philosophy of this model too, is positive engagement wherever we can. At the right time, very much like the Island Health, right person, right time. It really is about having the right people attending a scene and supporting somebody.
And again, that speaks into having good practice and knowing the resources in the community and utilizing the right people for each situation.
Yeah, and the mental health and substance use nurse is essential for following up, can follow up with somebody else. They can do some follow-up if the person is going to remain in place and connect to further MHSU continuum of care services. Another benefit to having the nurse is primarily stationed at the detachment, so there's lots of conversation, lots of discussion about, hey, what should I do in this situation? I'm sure Josh can speak to it more anecdotally, but so just having that healthcare presence within the detachment has it just creates opportunity for discussion and learning. And
therapeutic conversation, knowledge base, learning about each other's agencies. It's been really good.
Yeah, and they've had the opportunity to, or we've had opportunity to provide educational support to general duty members to
And not just police officers.
Yep.
the nurse and I have been to VIU to speak to criminology students about the role the police and healthcare play in the community. We've been to second-year nursing students, student programs at VIU. I've gone to high schools and talked to their law class. If early intervention is really important, if we can teach young people when to call the police and when it's appropriate to for these types of things, I think we're doing ourselves a favor. It's been really good, and some of the questions I get back from the young population is heartwarming. It's really, it's like, how are you looking after yourself in a job like this? I'm like, don't worry about me. This is what I signed up to do. I want to look after everybody else. So it's really heartwarming to get some of the questions.
And I think we want to just highlight too that this program, it serves everyone in our community. So if you're a parent and you're worried that your teenager is isolating and maybe experiencing psychosis, our general crisis team can come out, but if we're concerned about safety and risk, then the CAR 5-4 team is going to come and support you in your home to connect your child to services. So I think it's really important that it's any member of our community that could access these services at any time, and that's what we're striving to do. So right now it's a 4-day-a-week CAR, but we're looking forward to other opportunities.
The youngest person we've assessed is 6, and we've worked with GSS. So
Geriatric Specialty Services.
RCMP acronyms and Island Health pairing us together, you can only imagine. Yeah, so there's no limit. Tomorrow we could be there to see you. You never know. The mental health doesn't discriminate.
Yeah, thank you.
Thank you for the excellent work you do. It's very much appreciated by us and I'm sure by the Nanaimo community. So the more you can spread the word, the better. I think it's really terrific that there's a partnership between Island Health and the RCMP to care for people in the community who are in crisis. So really appreciate your work. Now we're gonna have a bit of a change in direction here. And I see Amanda's getting ready for the next presentation. And so it's my pleasure to welcome a presentation from Island Crisis Care, who in partnership with Island Health operates housing services at Samaritan Place in Nanaimo. And the incredible partnership here is going to be spoken about by Violet Hayes, Amanda Lemon, and Darlene Rye. So welcome to the podium. Would you, do you want another mic?
We can take
Yeah,
Can you? Okay.
This is just supposed to be at your mouth.
okay. Well, hello. It's wonderful to be here, and what a privilege. Thank you for the honor. And as mentioned, I'm Violet Hayes, the Executive Director with Island Crisis Care Society. And we've been around since the early 80s providing supports, and I just love collaboration, and so it's great to be here with these lovely ladies and to talk about what we've been able to do at Samaritan Place. And if you've been down to the south end, you've probably seen this building. It now has lovely landscaping. This is an older picture. It's been open just over a year. And so I'll let them introduce themselves, and then we're going to move on to the next slide.
Okay. I'm shorter than thank you. My name's Darlene Rye, and I work with Island Health Community Health Services here in Nanaimo, and have been involved with the Samaritan Place.
And I'm Amanda Lemon. I am a manager for community outreach services for mental health and substance use, and specifically the teams that work with Violet and her teams are primary care outreach, our sort of community treatment teams, what else? Substance use services outreach, and our community outreach response team.
Slide 2. Oh, it's you and I.
It's not working.
Okay.
There we go. Okay, do you want me to start?
You can do the initial history,
Okay.
and then I'll chime in.
Yeah, so we're talking about a service model within the site that Island Crisis Care operates. It's a BC Housing supportive housing site that Violet's team operates. And I guess we can go back to how we kind of got together with this service model is right in the very beginning of the pandemic in spring of 2020. We worked with a variety of community partners to identify some of our most vulnerable folks who were living on the street, so folks who were age 55 and up with some pretty serious complex medical health needs, many of whom had not been successful to remain housed at some of our other supportive housing locations within the community and had co-occurring substance use that complicated a lot of their physical health needs. So one of the BC Housing initiatives during COVID was to set up emergency response centers, and Violet's team at Island Crisis Care began to operate 35 beds? 35 beds at the old Community Services building downtown on Prideaux Street. And very quickly, once we identified who was moving in, really quickly recognized that their health needs were not going to be adequately supported, despite the very best efforts of Violet's team, is they were just too complex for the service model that existed. So Darlene can speak.
Yeah.
There was,
And I think that's when community health got involved, because basically Violet's team was really working beyond their scope to keep people housed, their personal care needs, and because it was going to potentially put their housing at risk, it was time for CHS to mobilize and take a look at what we need to do as a program. So we're home care nursing, we're case management, we're home supports, we're OTs, PTs, so we provide a big program of support to the community, and this was a special population that required us to be involved. So we set up these weekly meetings, basically, and initially, I think, home support was on the call, and Amanda's team and Violet, and we really problem-solved individuals. How are we going to get this client the care they need? Certainly within Community Health Services. It's a large program that has a lot of process, and it can be quite constrained in how to access supports. So we had to get to be a little bit creative, because these were clients that, they're our clients, and we have to meet their needs. So home support sort of worked within the constraints that we have to get some workers out. There was a group of us that went out to Prideaux and did an environmental risk assessment to ensure a safe working place, and definitely all the things that needed to be in place were, and we worked together to accommodate our workers going in to meet these needs. However, we certainly learned over time that this special population is not typical. I'm going to be there at 10 o'clock tomorrow morning and expect you to be there. So again, we had to be a bit more creative and work together over the next year as to how we're going to plan for Samaritan to open and what we need to do as a system to support folks.
So just as a bit of background, we had been at the old Samaritan House. Probably most of you are aware about Samaritan House. We were there for many, many years. It was over 100 years old. And so with the COVID funding, there was the need for the people that had been out on the streets with very severe medical needs. We had people that needed dialysis 3 times a week. We had people that were terminally ill, living on the streets. Like, that's just so hard to imagine. But through the funding with BC Housing, we were able to move into that building, as Darlene mentioned. And yeah, just exactly that, you know, how can you expect someone, you know, their lives are in chaos, and yet we were expecting them 10 o'clock, you've got to remember that you've got to be here, and often they weren't. So then we were struggling to even be able to support people because we just did not have the ability. Our staff don't do personal care. It's totally out of their scope. We care for them, we create community, but we needed Island Health to come on board, and boy did they. I'm just so thankful that they really did come on board. So Samaritan Place now is the next stage. It was kind of structured along, and so we were ready. We'd done this great job over at Prideaux. We were seeing people doing well, we lost, I think, 5 people while we were there, some to COVID, but some just to the conditions that they had. But we were able to really build that community. And then the next step was we were going to be moving into this beautiful 4-story building that had been planned, but yet what was going to happen to these ones who needed so much more? They didn't fit the criteria for supportive housing because supportive housing traditionally doesn't come with those medical supports. So we were like, okay, guys, what are we going to do now? Like, we have these people that we can't put them out on the street. We just couldn't do that. So that's where this great collaboration came together. And so what we ended up doing was the second floor was designated for the women. And so we have the women's bridge to housing or shelter beds on the second floor. And then on the third floor, we decided that we would make that the special medical needs floor. And so we were able to work together to make sure that the people on that third floor, we had to go through quite a few processes to make sure that they agreed to receive some help, and then put them there. And then now we have 16 hours a day, 7 days a week, we have home support there supporting. And what a difference it has made. Okay.
Yeah, so current state, and Darlene can maybe speak to it too, is I'll let you speak to it actually, Darlene, how you recruited your CHS staff there. But how MHSU is involved is when Prideaux Place was operating, we did have a mental health and substance use nurse there 5 days a week. And that nurse transitioned with all of the folks who moved into Sam Place at the same time and stayed there as a consistent person, really providing, she certainly has a mental health and substance use background, but was also able to provide all the linkages to all the health services so that Violet staff weren't responsible for creating health service linkages for all the folks with their complex medical needs at the site. And currently the primary care outreach team, many of you in the community would know the van, and with a team of a multidisciplinary team, physician, social work, nursing, and peer support, attend the site on a regular basis. So one of our community primary care providers has been attending weekly and trying to support all of the folks that live in the building. But Darlene, why don't you share
how we recruited our community health workers. So I think that what we decided to do as a program was to gather information about who was interested. So we sent out basically as an opportunity, because there are people who do want to make a difference in working with people, and this is a special population, and it can be very rewarding work. And so we did have quite a bit of feedback. We had, I'll say, 25 community health workers who said, yes, I'm interested, and we lost a few after we really explained what was going on, but beyond that, we provided educational opportunities. We had classroom curriculum by our community health worker educator. Amanda's team provided experiential, so our workers were able to shadow shift with a mental health worker, as well as we did some in-classroom training around mental health and substance use and cultural sensitivity and trauma-informed ways of working. So I think that our community health workers were feeling not only competent, but much more confident to go in that situation, to be working with this special population. Hey. Oh, and here's 2 of our staff. And my understanding is, since it was up and running and these folks were signed off on all their education, and that there was actually people calling in to want to work there. So that was certainly a testament to feeling I think for them to feel confident about doing that. Through the process of community health services working there, we needed to engage a case manager to follow through with our processes and create care plans and home care nursing as well. So we recognized again that a flexible working model was important. So we were going to send 2 workers, 2 shifts a day, with the importance of not just being completely task focused, that there was going to be a degree of needing to engage with people to build trust, rapport, and over time they would come to them when it was that their care needs might need to be met, or they'd be more agreeable to having their care needs once they got to know the workers. So I would like to say it's been what I consider to be a proud moment for Island Health to have worked with the systems, and that it's not without its challenges from day to day. There continue to be challenges, but I think because of the pathway and collaborative work we've done, we have open communication, and we look to problem solve, and we look to continue to, we don't just, quit services and that kind of thing because we're having problems. We really look to solve problems. And thanks to local leadership, senior leadership, we were able to get this work up and running, and I think it's a good model for communities. And all communities have this special population, so, yeah.
And along those lines, I just want to tell you a story. I love to tell this story. In the early days, I was in the program and met one of the community support workers. And so I said, oh, how's it going? Do you like it? And he said to me, well, I want to tell you, I was really upset. The scheduling put me in here, and I didn't want to come. And so and he said, what I discovered was, this isn't, he had said that he didn't like working in institutions. He said, but I discovered this is not an institution, this is a community. And so now I'm here full time. So that just goes to show how, you can really build community, and it just works so well. I want to just end with just a quote. I've got piles of them, but I've picked out one from one of the staff that work on the site. And she says this: a resident was with us that was in our previous program who struggles with addiction and health issues. He would often be gone for long periods of time, and we didn't know if he was safe or not. We reported him as a missing person numerous times, eventually finding out that he had been in hospital in a different community. After his hospital stay, he moved into his new home at Samaritan Place. He was very weak, was not eating, and not engaging with anyone. If he did not have the stability of a permanent home and the care of the home support team checking in on him to make sure that he was taking his medication, bringing him food, helping him with hygiene and many other things, he would not have recovered to the extent that he has. All staff has built a relationship with him. He will spend time with other folks in the TV lounge. He comes down for dinner and is able to do some housekeeping and even some cooking with the support he receives. He knows that he has people he can count on and to get out and get the help that he needs. We've met some of his family members. His son visits when he can and appreciates meeting the folks that care for his dad. So I just want to end on that and say that it's wonderful to see that there is hope for people, and we just need to work together to get there. Thank you.
Thank you very much. As a board and an organization, we deeply value our community partnerships. So we're very appreciative of you being here this afternoon to tell the community about the work you do, and we appreciate the work you do. So your quote was perfect. Thank you. Well, we are running a little behind. We had promised you to be out of here by 5 o'clock, and we're going to stick to that as best we can. So I'm going to turn it over now to questions from the floor. Please keep your questions really brief to allow us to answer as many as possible before we adjourn at 5 o'clock. If we don't get to all of your questions, then I'm looking over at Mike and thinking there will be a way for us to get questions and give answers by email or some other mechanism. Okay, that's great. Thank you very much. Question from over here. Well, actually, you had your hand up first, but it doesn't matter to me. Can you just use the mic because we can't hear you?
I'm William Donald McGilvery, a member of the steering committee of NANDU. I have a few questions, like car 54, why doesn't somebody with lived experience ride with you? That should be something that goes along with it, because we can talk to the people, right? Another one is, why did they tear down the old Samaritan house? There was bedrooms there was rooms there. Why couldn't they just kept that running? I mean, that was just kind of a waste. I'd like to have those answers. Thank you.
Thank you.
Can I just add, Psych Emergency Services releases the person that you've gone through all the rigmarole right away to the community. So someone had just texted me and she didn't get it in on time, so she just wanted to know if there was a comment about, then you guys are back at square one, and the parents are freaking out because she's a parent. Just
Sure, if you can, that'd be great.
Yeah, so Anne, the question was if someone, so say someone has been brought into the emergency department under the Mental Health Act and they see a physician and then they are discharged back to the community. Yeah, I mean, there's a variety of things that may have happened in that interim. Being someone who used to work in the emergency department, sometimes the crisis has abated a bit and you're able to create a plan with an individual. It really depends, but hopefully the connection has been made to a community mental health team that they can do some follow-up. All of the crisis team is mobile and should be able to engage with that person and their family if they still require care. And sometimes it might be a matter of, it may be that the team goes back out and determine the person does need to go back to hospital. So there's different opportunities, but yeah, it's often specific, but hopefully there's been some kind of follow-up arranged so that the person isn't lost to service.
This is just someone who's texting me.
Yeah.
Her son was held for 24 hours and then released, and no psychiatrist ever showed up at Nanaimo. And then he was released and arrested for being like, woo!
Yeah.
And he's in jail now. So just saying that, so those,
Yeah.
whether those kinds of things have been thought through, and do you have an advisory or some?
Yeah, we have a mental health advisory community or committee. Yeah. 100%, and those things come up all the time. So, but we can connect after too. Yeah.
Thanks, Amanda. One of the things that I need to say is that if you're going to talk about a specific situation, that's not for here. And there will be people around who might be able to help you at the end, but we're not really, we're here to talk about programs of Island Health and issues that you might have with that, but not about specific incidences. Thank you. So the gentleman in the back, or in the middle, I guess. Thank you.
Thank you. Yeah, this isn't a specific question. I think it fits in here. Unfortunately, I don't think it's going to be much more of an easier question. So in all the talk of safer supply, harm reduction, drug toxicity, poisoning crisis, our public servants are not adequately addressing the social determinants of poor health. We talk about community solutions, we talk about sharing the load, but clearly there are wealth, income, and privilege inequalities that make some better positioned to contribute than others, including right here in this room. Without naming names, a former provincial health officer as well as the scientific director of BC's major health research organization co-own an addictive opioid drug company, and the former deputy provincial health officer owns an addictive drug vending machine company. These individuals have influenced BC policies, safer supply policies and initiatives. Given the Stanford Lancet Commission's findings advising against profit-seeking with publicly supplied addictive drugs, glaring conflicts of interest like these are apparently common in our province, and yet they are not being acknowledged or actioned by our province's leadership. So my question is this: in what ways is Island Health and/or its officers, directors, staff contractually obligated or financially incentivized to refrain from characterizing opioid drugs as addictive, potentially lethal, or otherwise dangerous with a high risk of inducing dependency and addiction?
I'm not quite clear on what the question is. Sure, Reka, if you would be able to. Yeah.
In what ways, do you want me to do the mic again? Yes. In what ways is Island Health and/or its officers, directors, staff contractually obligated or financially incentivized to refrain from characterizing opioid drugs as addictive, potentially lethal, or otherwise dangerous with a high risk of inducing dependency and addiction?
So there, I think I understand the question, and I can.
It's a simple question.
Yes, I can clearly say that we are in no way. As a medical health officer, as a chief medical health officer of Island Health, and medical health officers within Island Health, for any advisory committee that we are on, we are required to declare any financial conflicts of interest. And certainly
That's not my question.
yeah, I'm having a little trouble understanding the question.
When you leave office, he's saying when you're finished your thing, then how do you know you're not gonna?
That's not the question either.
In this province who stand to gain financially through the manufacture, distribution, and sale of addictive, deadly drugs.
Right.
We are right now, we have coalitions of advocacy groups that are lobbying the provincial government to undermine the standards of care of pharmacists, of nurses, of doctors, to allow for the public supply of addictive drugs with no transparency, no accountability, and taxpayers are paying for all of it.
Okay, I think I understand the question now. So a couple of things I'd like to add. Two of the individuals you named are former officers, not current officers. So I would, well, no, but I think that's really important to say that while you're in office, there's absolutely no possibility of you participating in such advocacy. On the other hand, I would say that one of the things that we really need to get to is a shared understanding of what we mean by safer supply, by treatment with opioids, in order to understand that the risk associated with illicit drugs today is so significant. We are losing a person a day in Island Health, and therefore we are all working together as a community to find solutions that minimize the harms. It's minimizing the harms. There is.
So am I right here, right now. Like, accountability is a very large part of why we're in this mess to begin with, and why accountability is so important to actually solve it. Like, I don't work in the healthcare profession. I don't give a damn who doesn't like me here, but I tell you right now, the taxpayers of British Columbia are so fed up with what's going on here. Like, we need to call a duck, right? Like, that's what was said earlier. Call it as you see it. I call BS. There is an awful lot of gaslighting the public happening right now, an awful lot of being treated like we're children, like we don't understand, and if maybe we had a medical degree, then maybe we would be smarter and be able to handle this. We're grown-ups, and we know what's going on. We need to get people off the drugs that are killing them. Like, I've lost people too.
I couldn't agree with you more. We do need to get people off the drugs that are killing them. And that is our shared goal. And I think one of the things that is happening today is that we aren't able to have conversations that go from the people who are, you mentioned, people who are with lived experience. We need their voices. We need your voices. We need the medical profession's voices, but we also need the voices of people who are using, people who are not using, people who are worried about their children. So I think one of the things that we really need to create is a table, and many tables in communities where we can speak to each other and build a shared understanding. This is one of the most complex social situations that we have faced over many, many years. And the solutions aren't simple, and accountability and understanding and actually gathering the evidence are absolutely equal and important parts of that. So I think the passion in your voice, for me, reflects the importance of this issue, and this is hard work to do. And I and Highland Health, I think, are very prepared to work with everybody in our community to start addressing them.
Thanks very much, Reka. Thanks for your comments and questions. So we have one more here, and I think that's unfortunately going to be the end of our questions because we're running out of time.
My name is Ken, and I am a senior in this lovely city. Great presentation. Unfortunately, it only addresses a small population of the city. One thing with the size and the population of this city, we have one drop-in clinic. And I was hoping to hear something from Island Health about what they're going to do about opening possibly another one. We need this. These drop-in clinics service seniors, taxpayers, members of society. Those people are being ignored right now.
So could you just be more specific about what you mean by a drop-in clinic? There's
only one. There's only one drop-in clinic, and it's down south. It's in Ottawa South on Terminal Avenue. Primary care clinic, drop-in clinics. You know, we have no doctors. We can't get a doctor. But yet I did not hear anything here about what the city's going to do to help us. I know you can't help us getting a doctor, but we definitely need a drop-in clinic, at least another drop-in clinic for our health, because we're not getting any better. We're getting older.
Well, I think Kathy mentioned, do you want to go ahead?
Sure.
Okay,
Yeah.
go ahead.
Thank you. And I think the issue around the lack of access to primary care is consistent in every community in British Columbia right now, unfortunately. In fact, in Canada. I know there are plans underway to work here in Nanaimo to look at what we can do around a second urgent primary care center. So that work is underway here. The provincial government just settled an agreement with the Doctors of BC that has enhanced significantly the payment model for primary care practitioners. We're quite hopeful that that will have a positive impact in terms of the number of people who decide to go into primary care practice. And so I think that we have 3 new to practice primary care physicians coming to the community and 3 more in negotiations. So there are some new recruits coming, but I couldn't agree with you more. I too don't have a primary care physician. And I will put in a plug for those of us who don't have a primary care physician. There are some tools like there's a Health Connect where you can go on and put your name in, which I know the wait times depending on the community are long, but those new to practice physicians and nurse practitioners are pulling people's names off that list, the Health Connect database. And as well, I would encourage anyone to sign up for a patient portal where your health information is available to you so that you have access to your own information to help you navigate the system. And for me personally, that's been quite helpful.
Thank you, Kathy. Well, as a governance board, we try hard to come to the various communities around Vancouver Island and to hold public forums so that we can hear what some of the issues are from a particular community. So we really appreciate you coming this afternoon. It's really important for us to hear what your issues are. And we have had people online as well, but we haven't heard any issues from them because they don't have the ability to ask a question out loud. But in particular, I want to thank Kathy, Sandra, Josh, Amanda, Violet, and Darlene for your presentations. And I want to thank all of our staff who are here because I know they're working very hard to try and ensure that the issues that you've raised today are dealt with in a good way. And I want to recognize our communications folks and our multimedia people who have been responsible for getting us into this room, making sure that people can hear us live stream, having the ability to ask questions, recording this, and so on. So thank you, all of you who got us here today. It's very much appreciated. And so, yes? No, I appreciate that, and I'm sorry. Normally, we would give you more time. It's just that we underestimated.
What my question is can you give us direction as to where we can send our questions and comments?
So, Mike, do you want to? Ask the board at islandhealth.ca is where you can send your questions. And I will absolutely guarantee you'll get an answer.
I think I reply. I got 10 questions that were not replied to.
Unfortunately, I'm going to have to wrap this up. I sure appreciate everybody joining us today. And I hope that we will be able to answer your questions if you send them into that website that I just, or that email address that I just mentioned. Thank you so much.